Sure. So cisplatin is well known to cause sensory neural hearing loss, which is a type of hearing loss that results from the death of what are called hair cells inside the cochlea. There are outer hair cells and inner hair cells. Both of them play a role in developing nerve impulses as a result of sound that we perceive. When those are damaged by cisplatin, they can no longer do that. Usually the hair cells that are responsible for high frequencies begin first, and those drop out initially, but with continued treatment with cisplatin, the hair cells drop out progressively to involve lower frequencies as well. So studies overall that look at hearing loss in children indicate that about 40 to 70% on average develop hearing loss that's clinically significant. But there's a big range in that, and it does depend on some factors like age and also the dose of cisplatin that's used, and sometimes other cancer treatments. So we know that for very young children, they're at much greater risk for hearing loss than older children and teenagers are. Patients that receive treatment that involve a lot of cisplatin or carboplatin are at more risk as well. Particularly patients who receive radiation therapy to the brain that affects the cochlea where those hair cells are can have additional risks. And then finally there are other medications that are sometimes used, like aminoglycoside antibiotics, for example, are common for children with cancer who get infections. Those can actually worsen the hearing loss as well. I think what's important where we are in 2017 with the issue of cisplatin-induced hearing loss is that we now have some options for what I like to call challenging the paradigm. And it's the paradigm historically that we have to accept this problem, that there is really no alternative than to give the chemotherapy in order to cure patients. And in an era where we did not have an option to prevent it, that is an understandable paradigm and probably somewhat unavoidable. That's the paradigm of continuing cisplatin treatment, knowing that it's causing hearing loss in the face of hearing loss, or at best possibly modifying hearing loss. So option one is the old paradigm of continuing cisplatin no matter what. A somewhat newer paradigm that is largely in practice now, which is to give the cisplatin until hearing loss begins, and then begin to modify it if it's severe enough, and reduce the dose or hold the doses or substitute medications. But the problem with that is that that's unsatisfactory, because those children have already developed hearing loss. You're not taking action until after the problem has already begun. And the third paradigm, which is the paradigm of the present, is using medications that can prevent the hearing loss and actually prevent the problem from developing. And I think that's the area that we are in. It's the one we need to pursue. Sodium thiosulfate is a drug that's been tested now in 2 randomized clinical trials, and we need to look carefully at those results to see what effect they're having. The COG trial indicated that the hearing loss is reduced with that drug. The SciAppell results will be released later today, and I think if those are consistent, then we need to take a good hard look at whether that agent has a role in preventing hearing loss. At the same time, there's additional research going on right now, and it's an exciting time to be alive, frankly, because I think over the next several years we're going to see nothing but increasing energy around this area with new agents, new options that will give us ways to prevent this problem in ways that we could never even think of before.